your diabetic patient's life with uncompromising quality and efficacy. It's time to offer them hope beyond possibilities, health beyond limitations, happiness beyond expectations. In T2DM with multiple risk factors, prescribe Dapavel. Wellness beyond diabetes control. Diabetes, one of the most dreaded disease in the world today, consuming hundreds of lives as we speak. But diabetes is just the tip of the iceberg. It's the underlying threats of diabetes that compromise and complicate the patient's wellness. The need of the hour is a therapy that offers wellness beyond diabetes control. In TAS, leaders in cardiodiabetotherapy unveils a new era of wellness for diabetes patients, introducing an innovative and holistic approach beyond glycemic control and emphasize heart and kidney protection. Dapavel, wellness beyond diabetes control. Indian phenotype T2DM patients in particular have multiple risk factors and are at high risk of cardiorenal complications. Transform their harsh reality into healthy possibility with Dapavel. Dapavel offers powerful glycemic control. Large studies have shown cardioprotection and renal protection with or without diabetes with dapagliflozin. Every sales pack of Dapavel shares your precious advice with the patient. Uncomplicate your diabetic patient's life with uncompromising quality and efficacy. It's time to offer them hope beyond possibilities, health beyond limitations, happiness beyond expectations. In T2DM with multiple risk factors, prescribe Dapavel. Wellness beyond diabetes control. Diabetes, one of the most dreaded disease in the world today, consuming hundreds of lives as we speak. But diabetes is just the tip of the iceberg. It's the underlying threats of diabetes that compromise and complicate the patient's wellness. The need of the hour is a therapy that offers wellness beyond diabetes control. In TAS, leaders in cardiodiabetotherapy unveils a new era of wellness for diabetes patients, introducing an innovative and holistic approach beyond glycemic control and emphasize heart and kidney protection. Dapavel, wellness beyond diabetes control. Indian phenotype T2DM patients in particular have multiple risk factors and are at high risk of cardiorenal complications. Transform their harsh reality into healthy possibility with Dapavel. Dapavel offers powerful glycemic control. Large studies have shown cardioprotection and renal protection with or without diabetes with dapagliflozin. Every sales pack of Dapavel shares your precious advice with the patient. Uncomplicate your diabetic patient's life with uncompromising quality and efficacy. It's time to offer them hope beyond possibilities, health beyond limitations, happiness beyond expectations. In T2DM with multiple risk factors, Prescribe Dapavel. Wellness beyond diabetes control. Diabetes disease in the world today, consuming hundreds of lives as we speak. But diabetes is just, it's the underlying threats of diabetes that compromise and complicate the patient's wellness. The need of the hour is a therapy that offers wellness beyond diabetes control. In TAS, leaders in cardiodiabetotherapy unveils a new era of wellness for diabetes patients, introducing an innovative and holistic approach beyond glycemic control and emphasize heart and kidney protection. Dapavel, wellness beyond diabetes control. Indian phenotype T2DM patients in particular have multiple risk factors and are at high risk of cardiorenal complications. Transform their harsh reality into healthy possibility with Dapavel. Dapavel offers powerful glycemic control. Large studies have shown cardioprotection and renal protection with or without diabetes with dapagliflozin. Every sales pack of Dapavel shares your precious advice with the patient. Uncomplicate your diabetic patient's life with uncompromising quality and efficacy. It's time to offer them hope beyond possibilities, health beyond limitations, happiness beyond expectations. In T2DM with multiple risk factors, prescribe Dapavel. Wellness beyond diabetes control. Diabetes, one of the most dreaded diseases in the world today, consuming hundreds of lives as we speak. But diabetes is just the tip of the iceberg. It's the underlying threats of diabetes that compromise and complicate the patient's wellness. The need of the hour is a therapy that offers wellness beyond diabetes control. In TAS, leaders in cardiodiabetotherapy unveils a new era of wellness for diabetes patients, introducing an innovative and holistic approach beyond glycemic control and emphasize heart and kidney protection. Dapavel, wellness beyond diabetes control. Indian phenotype T2DM patients in particular have multiple risk factors and are at high risk of cardiorenal complications. Transform their harsh reality into healthy possibility with Dapavel. Dapavel offers powerful glycemic control. Large studies have shown cardioprotection and renal protection with or without diabetes with dapagliflozin. Every sales pack of Dapavel shares your precious advice with the patient. Uncomplicate your diabetic patient's life with uncompromising quality and efficacy. It's time to offer them hope beyond possibilities, health beyond limitations, happiness beyond expectations. In T2DM with multiple risk factors, prescribe Dapavel. Wellness beyond diabetes control.
Good evening, everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this fourth edition in the webinar series Spotlight SGLT2 inhibitor. Today, we are going to discuss about one of the important aspects in the management of diabetes with the use of SGLT2 inhibitors. And today, we are going to discuss about how SGLT2 inhibitor provide us benefit to the various mechanism and what are the benefit in terms of vasculometabolic benefit and vistometabolic benefit. And to moderate today's session, we are lucky to have with us Dr. Rishi Shukla sir. Dr. Shukla is a head of the Department of Endocrinology at Regency Hospital, Kanpur, and Chief Consultant Center for Diabetes and Endocrine Diseases, Kanpur. He is having rich experience of more than 25 years in the field of endocrinology. He is a regular faculty in various international conferences, including EASD and ISPAD, and many more in the list. He is a recipient of Economic Times Recognition Award in year 2018. He is a member of ESI RSSDI Clinical Practice Recommendation for the Diabetes Management 2020 guidelines. He was an investigator in many global clinical trials and running regular patient education programs since last 25 years by the Organization Society for Prevention and Awareness of Diabetes in Kanpur. So without further ado, I would welcome Dr. Rishi Shukla sir to Digital Podium. So over to you, sir.
Thank you, Dr. Mithilesh. Thank you, Intas. Thank you, Amit. Thank you, Gaurav, and thank you, entire team, for the invitation. And good evening, friends, all across the India. And today we are going to discuss the very relevant and useful topic on SGLT2 inhibitors. And before I introduce the topic, a word about SGLT2 inhibitors. I think SGLT2, enough of SGLT2 now. But don't you think they are so interesting, so useful, and we have gone a big way in management of diabetes? Because empagliflozin was the first molecule that was launched in our country, because DAPA that had a fear of bladder cancer, so it could not be launched. So I asked the question, can you give it to eGFR below 45? Then the answer came, sir, you cannot give because recommendations are not there. Then the other question I asked, if you give, what will happen? Then the answer was same, sir, it is not the recommendation. Then I asked, offline can we give? Sir, I don't have any answer. From that point onwards, things started, and we have had a very big journey, not only in terms of blood sugar control, in terms of cardiovascular benefits, in terms of renal benefits, but we moved one state ahead. And that was exactly the question that I asked at that time, can it be given to non-diabetic? Now we have data for diabetes as well as non-diabetes. And so we went in a big way. Whatever we discuss about SGLT2, it is still useful, because all the physicians all across the country who are listening to these dialogues on SGLT2, for every patient, I think the thought comes, can we give and can we protect our patients, be diabetic and be non-diabetic? With this, I would like to introduce the first speaker, and the topic of today's talk are two: vasculometabolic axis and the visceral metabolic axis. So first speaker is Dr. Sanjay Kalla. He's going to speak on vasculometabolic axis, and the vascular protection, vascular part is actually a very, very important part. And through this, we have shown lots of benefits. Dr. Sanjay Kalla has been working as a consultant endocrinologist and head at Bharti Hospital, and he has done super specialty DM from most prestigious institute of the country, All India Institute. He's a past president, Endocrine Society of India, vice president, South Asian Federation of Endocrine Societies, education editor, International Society of Endocrinology, section editor in endocrinology, API textbook of diabetes. This is all printed in introduction, but I appreciate this young man. With such a young age, he's rose very high, and I wish that he should go even higher. And one thing, he's a wonderful person and a very helping and positive man. With this, I would request Dr. Sanjay Kalla to initiate with his talk. And he's a very, very innovative and very insight speaking person. Dr. Sanjay, please.
Thank you, Dr. Rishi Shukla, sir, for those warm words. It feels very good, actually, to be called young, especially by someone who himself is considered the evergreen hero of Indian endocrinology. So that is a wonderful compliment to get from someone who deserves that compliment himself. Like Dr. Shukla said, SGLT2 inhibitors are really interesting. Every time you talk about them, there is something new to explore. And that's what we'll do today. I will speak more about the traditional aspects of SGLT2 inhibitor pharmacology. We'll talk about the vasculometabolic axis. And then our senior speaker, Dr. Arpandev Bhattacharya, sir, who is equally young at heart, he will expand our horizons further and he will talk about newer vistas that we're exploring with SGLT2 inhibitors. Dr. Rishi spoke about being young, and actually from time immemorial, there has been this quest for immortality, for youth. This quote comes from the oldest existing book in the world. The oldest existing book in the world, which was written in Mesopotamia. And this is what the hero says. He says, there is a plant that looks like a box thorn. It has prickles. It will prick you. But if you can possess this plant, you will be as you were in your youth. This is known as the plant of heartbeat. It gives a man vigor. I will take this plant and I will give it to ancient peoples, which means to elderly people. I will put the plant to the test. I will see whether actually this can give me immortality. Now, this is what we have been trying to achieve from time immemorial. Even if we cannot achieve immortality, we certainly do want to achieve a longer lifespan, a healthier lifespan for all our patients and for us. And this is the book that this quote comes from, the Epic of Gilgamesh. And Gilgamesh is the hero who goes out in search of that plant which can give immortality. When ancient physicians began learning about life, about biology, they coined the word metabolism, which comes from the Greek change. Metabolism is a set of life-sustaining chemical reactions. They take our food and convert it into energy so that we can survive. But then they also take that food and can use it as building blocks to create lipids, to create proteins, carbohydrates, so that we can create reserves of energy. Even if we were to undergo a period of famine, of starvation, we would still be able to survive. At the same time, metabolic reactions allow us to eliminate unwanted waste products. So at the same time, two processes are going on. One is anabolism, which means building of protein, building of glycogen. At the same time, catabolism is going on, where these are being broken down into small bits and pieces so that we can survive. Metabolism is not a modern concept. Exactly the same thing is seen in Ayurvedic philosophy. Now, some of us may feel surprised. Why is it that we are starting a discussion on SGLT2 inhibitors, perhaps the most cutting-edge drug that is available in modern metabolism, in modern technology? Why is it that we are starting this discussion with Ayurvedic philosophy? The reason is that this is important. It is necessary. Our Ayurvedic colleagues also use the concept of metabolism. They divide all beings into Vat, Pith, and Kaph. They do not focus only on the physical phenotype. I, for example, am a Kaph phenotype, a metabolic syndrome phenotype. Dr. Shukla, our chairperson, is a Pith phenotype, a eubolic or a sattvic phenotype. Vat would be somebody who is very catabolic, very malnourished, anorexic, the typical picture of uncontrolled type 1 diabetes, uncontrolled Graves' disease, pancreatic diabetes. That is the Vat picture. But in Ayurveda, they focus not only on the physical phenotype, they also look at the psychophenotype and the preferences of the individual. And then they also look at the body fluids like tears, sweat, urine, and stool. All this put together can give you a multiple permutations and combinations of metabolic setup. It is important to understand this, because if we speak this language with our patients, you will find that many patients who tend to assume that everything alternative is good for health and everything allopathic is bad for health can be reassured. So what we tell them is that what we are doing in our clinic, we are classifying you into catabolic and anabolic or eubolic. This is exactly the same thing as is done in Ayurveda. It is just that the words are different. So in my practice, what I do is when I have to choose glucose-lowering therapy, I classify all people into those who have maladaptive anabolism. It's not adaptive if you are overweight or obese, if you have high blood pressure or dyslipidemia. Actually, it is maladaptive because there is a lot of insulin resistance, and it's this that is causing uncontrolled diabetes. Here, our choice of drugs is going to be different, totally different as compared to a diabetic person who comes to me with predominant catabolism, thinly built with insulin deficiency. Here, I will choose different drugs. If I can do this metabolic triage with my MPD, with inspection, with palpation, and with a few basic biochemical tests, I can choose the right drug. But it is not enough just to control glucose. We have to look at all the other things that come along with glucose, the bag and baggage that comes with it. And when you have maladaptive anabolism, you will have what we call the metabolic syndrome. I was a student when the term metabolic syndrome was coined. Dr. Arpan and Dr. Rishi Shukla sir both were much younger than they are now. And at that time, there was a lot of discussion about the definition of metabolic syndrome. Nobody could even come to a consensus as to how to define metabolic syndrome. So you see at least 5 different types of definitions here. But you can see that there is synergy, there is concordance, because practically the same clinical parameters or the same biochemical parameters are being used to define metabolic syndrome. And I learned this as a student with the acronym DHOL. DHOL means drums, and the drums of metabolic syndrome beat loud and strong in our country. So dysglycemia, high blood pressure, overweight, hyperlipidemia, and in Uttar Pradesh, where our chairperson is from, they don't use the word DHOL, they call it DHOLki. So Ki reminds us of microalbuminuria. With all these definitions, it was said that urine albumin should be focused on. And why should we look at albumin? Because this is actually the bridge between macro and microvasculature. If there is a bridge between micro and macrovasculature, does it mean that there are drugs which can help us impact both macro and microvasculature? Are there drugs that can act on each and every aspect of the DHOL or the metabolic syndrome? Until recently, the answer was no. But now we have SGLT2 inhibitors, which not only help improve glucose levels, they also give us vasculometabolic and viscerometabolic benefits. The tougher part of today's session will be taken care of by Dr. Arundev Bhattacharya sir. But let's focus on the vasculometabolic benefits. Now, traditionally, we divide our vasculature or our vascular tree into the macrovascular bed and the microvascular bed. We also know that there are vascular risk factors that we have to look at if we want to reduce CV risk. In macrovasculature, we have 3 typical beds that we look at: the coronary arteries, the cerebrovascular bed, and the peripheral arterial system. Let's look at these one by one and see how SGLT2 inhibitors fare. This is known to all of us. In general, SGLT2 inhibitors reduce major adverse cardiovascular events, especially in patients who have established ASCVD. They also reduce CV death. Depending upon the subset that is being analyzed, you may have a statistical significance or a numerical significance. But there is no denying the fact that SGLT2 inhibitors are favorable for overall cardiovascular health. And this is especially seen when we focus on hospitalization for heart failure. Here you see that irrespective of the type of drug that is used, the type of meta-analysis or sub-analysis that is done, you will find that SGLT2 inhibitors actually reduce hospitalization for heart failure. This is important because, as you know, over the past 20 years, cardiology, internal medicine has made a lot of strides, has really improved the quality of management of coronary artery disease, and death rates due to IHD coronary artery disease are coming down. However, hospitalization for heart failure continues to increase, not only in India, but in the developed world as well. So we have SGLT2 inhibitors, which can be used to improve cardiovascular health, especially health related to heart failure, which means myocardial health. So not only coronary, but myocardial health is improved with SGLT2 inhibitors. The beauty is that this advantage extends even to non-diabetic patients, people with pre-diabetes, people with euglycemia. And the DAPA-HF, DAPA heart failure study, that showed that in people with heart failure and reduced ejection fraction, dapagliflozin was beneficial in reducing hospitalization for heart failure, urgent heart failure visit, and CV death, the composite of all this. This concept is known as endocrine exaptation. We are able to exapt endocrine drug now for use in non-endocrine situations. Some people say that dapagliflozin is a drug for the cardiologist. What we say is that it is a drug for humanity. It is a drug for everybody. It should be used by all healthcare professionals in a rational manner. Some people say that it is a non-endocrine drug. The cardiologists say that. To get our answer is the heart is an endocrine organ. There is no denying the fact that the heart is an endocrine organ. It is a source of hormones like BNP, proBNP. It is a target of hormones like adrenaline. If you have endocrine dysfunction like hypothyroidism, hypocalcemia, you can go into cardiomyopathy. So it is an endocrine organ. And there is no cardiologist who can treat heart failure without using endocrine hormones for diagnosis and screening, without using endocrine hormones for treatment. Dopamine, dobutamine, these are endocrine based. So it's just an endocrine organ, and we should stop that discussion. We should instead think about humanity and about improving our results. If you look at cardiovascular, we find absolute benefit with the SGLT2 inhibitors. When we look at stroke, the effects of SGLT2 inhibitors on stroke, they are equivocal. But the number of events actually were so less in all the trials, the stroke-related events, that we could not reach any statistical significance. However, it is said by experts that a benefit is more likely than harm. You must remember that there is a protective effect for hemorrhagic stroke with SGLT2 inhibitors, though it is just numerically significant. The numbers were too small to give any meaningful statistical analysis. But look at statins. See the difference here. When you use high-dose statins, you are able to reduce TIA. You are able to reduce ischemic stroke. But hemorrhagic stroke actually goes up with high-dose statins. There is discordance in terms of CV risk reduction with statins. But here we have concordance. So that is one very good point about SGLT2 inhibitors. Similarly, for peripheral arterial disease, otherwise earlier there was a lot of issue about the impact of canagliflozin specifically on peripheral arterial disease and amputation. But based upon later trials, later evidence, actually FDA removed the boxed warning. So now there is no risk of increased amputation with any of the SGLT2 inhibitors, whether it is canagliflozin or the other ones. We've spoken of the three macrovasculars. Let us look at microvasculars. Here the most important is the kidney, because in microvascular complications we talk of nephropathy. We also talk of the retina, because retinopathy can occur, and neuropathy. Let's look at these one by one. When you see the kidney, again you see that across board, SGLT2 inhibitors improve kidney outcomes. They reduce progression of albuminuria. They also reduce the risk of developing end-stage renal disease or worsening of serum creatinine. Note here another difference between SGLT2 inhibitors and RAS blockers, ACE inhibitors. ACE inhibitors are proven to reduce the risk of progression of microalbuminuria to macroalbuminuria. But there is no data to show that they can prevent the progression of normoalbuminuria to microalbuminuria. In SGLT2 inhibitors, you have data across board. Irrespective of the renal phenotype, what kind of eGFR there is, what kind of albuminuria level there is, you will find that SGLT2 inhibitors actually reduce progression. They actually enhance regression. So they bring the albumin grade down towards a healthier level. And this is done because they are able to reduce podocyte injury. And this electron microscopy shows that dapagliflozin is actually able to improve the anatomy of the podocytes in the glomeruli. We showed the difference between SGLT2 inhibition and RAS blockade based upon evidence, but you can use them both in practice. They complement each other, and both of them should have a synergistic effect on renal health. Because of this, the KDIGO guidelines published just a few months ago, November last year, recommend treating patients with type 2 diabetes and CKD, and now they go up till an EGFR of 30 or more with an SGLT2 inhibitor. Now, many of you will say, what about the labels in India? So the label says 45. Others will say, the KDIGO people must be saying the right thing, but in my OPD, I don't think some of my patients follow this advice. Here, what I would like to say, and we would like comments from our senior members, Dr. Shukla and Dr. Appan. When you see a patient, good clinical sense comes first. Inspection comes first. History taking comes first. Only after that will you measure the EGFR. If you have a patient with an EGFR of 31, feel free to prescribe an SGLT2 inhibitor. But if that patient is suffering from uremic gastritis, is vomiting, has hematemesis, if that patient is suffering from tuberculosis, he has hemoptysis, if the patient is losing weight 3 kg every week, then that is not a good patient for SGLT2 inhibitor. So good clinical sense will come first. If you have a stable patient, then certainly prescribe SGLT2 inhibitor. How many of our patients are stable? Here we look up to something known as Pareto's law, P-A-R-E-T-O. Pareto was an Italian economist who said that 80% of all of Italy's wealth is owned by 20% of Italians. In our country, it might be 99-1 actually. 99% of our wealth is owned by 1%. But that is a separate matter. In my OPD, how does Pareto's law operate? 80% of all the troubleshooting, 80% of all my stress and frustration is because of 20% of my patients. They keep on coming with some acute problem or the other. So if you have somebody with chronic kidney disease, but that person is always coming in with an acute complication, it may not necessarily have to be acute kidney injury. Any acute symptom, sign, or lab abnormality. Then these are people where SGLT2 inhibitors should be given with caution. Ensure that you are able to monitor them very carefully, very regularly before prescribing. If however your patient has stable CKD, feel free to prescribe this drug. It will actually do wonders. Same if you have somebody with stable coronary artery disease, chronic stable angina, this drug will do wonders. Stable heart failure, it will do wonders. But if you have a patient with acute decompensated heart failure, patient is hemodynamically unstable, you are struggling with 1, 2, 3 pressors, you are not able to bring the BP up to 90/60. Patient has renal instability. The serum creatinine is rising 0.1, 0.2 every 24 hours. It has not met the threshold for acute kidney injury, but still serum creatinine is rising. Avoid GLP-1R and SGLT2 inhibitor. If your patient is gastrointestinally unstable, not taking adequate carbohydrate orally, not absorbing adequate carbohydrate orally, then avoid these drugs. But if your patient has chronic stable angina and is hemodynamically stable, renally stable, and gastrointestinally stable, then again, these drugs are the drugs of choice. So now that we have put this in perspective, now immediately we know which of our 80 patients to prescribe this drug. And the beauty is we spoke of endocrine exaptation. Here, what is happening in this slide, in this study, DAPA-CKD, even in CKD that is not due to diabetes, dapagliflozin actually helps improve renal health. It improves long-term outcomes. And you can use it up till an EGFR of 25 also. For retinopathy, again, the numbers are so less that there is no absolute statistical data available, but there is potential benefit certainly, and more data is required. Similarly, for neuropathy, the mechanistic studies show that SGLT2 inhibitors will probably improve peripheral neuropathy. So many times we have patients with with the resistant neuropathy, refractory neuropathy. They just do not respond to whatever medication you are giving. That medication, that neuropathy can have positive symptoms, negative symptoms. There is no harm in adding SGLT2 inhibitors as part of glucose lowering therapy and also as part of therapy which will modulate the microvasculature. We've spoken of macro and microvasculature, but we forgot the risk factors, the vascular risk factors. Let us summarize that when you use dapagliflozin, you are able to get good improvement in systolic blood pressure. You may actually have to reduce the dose of diuretics, especially in North India in the summer months. This blood pressure reduction is much more in our country, in Asians, as compared to whites and blacks. So we should be more careful. And this blood pressure reduction also is not limited only to the daytime or to the night. It actually improves the diurnal variation of blood pressure. So in multiple ways, it helps improve cardiovascular health. There is a synergistic effect over and above ACE inhibitor or ARB. So again, if you have a patient where, let us say you are using 2 drugs, 3 drugs for BP control, and now you feel I will have to label this patient as having resistant hypertension. Maybe you are at 5 drugs, you feel that I will have to label this patient as having refractory hypertension. Just do a therapeutic trial with SGLT2 inhibitors and see what happens. You will be pleasantly surprised with DAPA. And all these cardiovascular protective effects, they work in multiple ways. And it's not that blood pressure is an end in itself. By controlling blood pressure, by improving the diurnal variation, they reduce the risk of heart failure, they reduce the risk of CV mortality. For dyslipidemia also, we have mixed results, but HDL cholesterol increases with SGLT2 inhibitors. So remember that HDL is always low in most Indians. So remember that. And also the type of LDL particles change, they become more healthy with SGLT2 inhibitors. So there is a modest improvement here as well. And again, if you're struggling with HDL, if your patient is after you, that's why is my HDL 38? Why is it not going up? You can always try this. Biomarkers of inflammation are also reduced. Biomarkers of oxidative stress are reduced with the SGLT2 inhibitors. And so therefore, you remember we began with this story of Gilgamesh, the epic of Gilgamesh. He went out in search of a plant which could provide immortality. Is it true that we now have a drug or a drug class which is able to act on virtually every aspect of the metabolic syndrome, which is able to act on a wide spectrum of cardiac and renal impairment, which is able to act not only in people with diabetes, but also in persons without diabetes, and which is able to improve the entire vasculo-metabolic axis? If so, it is possible that SGLT2 inhibitors are the modern Lycium barbarum. This is the flower that Gilgamesh was searching for. So thank you, and we look forward to comments from our chairperson, comments also from the entire house across our great nation. And then, like I already said, the tougher part is to be handled by Dr. Arpandev Bhattacharya. I look forward now to sitting back, relaxing, and learning from sir. Thank you.
You need to unmute first.
Thank you, Dr. Sanjay, for very nice and interesting dialogue on SGLT2 inhibitors. You touched the vascular part. I think one comment I'll make, it's a finding that you are one of the perhaps only or maybe the few, I don't know anyone other than you, who tried to correlate mythology and other sciences with modern medicine. Kab Faat with Rishi Shukla, Sanjay Kalla, such a wonderful explanation you have. I truly loved, and I think if you have read Brian Weiss, the psychiatrist who wrote a lot of articles on spirituality, and he tried to make it very objective. So maybe one day I would like to discuss with you and try to correlate with our endocrinology as well. I think we'll have a great discussion and comments little later, and it's a privilege and pleasure to invite Dr. Arpandev Bhattacharya. He is DNB Medicine, DM Endocrinology, MRCP, FRCP, CCST, with very prestigious degrees. And he is MD and DM Endocrinology from prestigious PGI Chandigarh, consultant endocrinologist, Department of Diabetes and Endocrinology, Manipal Hospital, Bangalore, Professor of Endocrinology, JJMC, Davangere, Karnataka, Co-Chair, Shivajyoti, Indira Nagar, Bangalore, dedicated setup for treatment and research in diabetes and endocrinology, pioneered the fellowship program in diabetes and endocrinology with Manipal Academy of Higher Education to train post-MD physicians, more than 120 publications in various national and international journals. So this is the written introduction, but he's a very knowledgeable person, a wonderful human being, and I was lucky to be together with him at PGI Chandigarh. And he's going to speak the visceral aspect of SGLT2, the brown fat and the white fat and the ATPs. I think it's a little complex. Dr. Sanjay, perhaps you are right. It's a little challenging task. So I'll request Dr. Arpan Dev Bhattacharya to please proceed, and then we'll have question and answer session. Dr. Arpan, please.
Good evening. Thanks, Rishi. Thanks, Nintus, for bringing us in the virtual platform. Now, as it's customary to tell that my previous speaker has done my job easy, actually it's completely opposite. My previous speaker has done my job very difficult because he has raised the level of expectation so much, I don't know what I'm going to do. And you know Sanjay Kalra, and we'll discuss about Sanjay Kalra a little bit in our chit-chat session. And I think he will have a good prospect in the cabinet. We need to recommend Mr. Modi, actually. So this is what I'm going to talk for the next around 20-22 minutes. And this is a simple disclaimer. I do not have any share in a pharmaceutical company. And in today's meeting, I am a contracted speaker at the Intus, and the views expressed are essentially of mine, has nothing to do with the sponsor. This is what we are going to discuss, okay? SGLT2, viscerometabolic bed. He is the only person in my country can coin this type of word is Sanjay Kalra. He coined the word like glucocrinology, osteocrinology, and never this term. And when the first invitation was going, the subcommittee came to me, can you approve the subcommittee invitation? I'm telling Sanjay Kalra talking on viscerometabolic disorder and Arpan Dev Bhattacharya talking on visceral. What is this going on? Then I realized this is a vascular and the visceral, and that is the story. Okay. Slides new because there is so much ubiquitous effect of SGLT inhibitors. It's very difficult to separate them. So I'll be quickly pass on through whichever slide Sanjay has focused. This is the unfortunate story about the diabetes epidemiology, what is going on in the world. And we all know this, we have seen these slides, but interestingly, I wanted to show you this slide, which is, to me, is actually a very good eye opener. This is done in 2019. Indian people, age 15 to 49 years. For every 100 diabetes people, half of them are not aware they have diabetes. People who are aware, half of them are treated, another is untreated. And people who are untreated, 1 in 4 is controlled. Can you believe that when you are coming, how many people are controlled diabetes on the beginning number, where it will go? And that's the part of the story. We don't have a polling button or something, but I want to put a question and I will answer at the last about this question, what I think. Now, this is the question. You need to pick up the one you think most important. You may tell all 5 are correct, but unfortunately, there is no option, is there all of them. So you'll have to pick one of them. So aim of treatment for type 2 diabetes, option 1, reduce HbA1c. Option 2, reduce symptoms of high blood. Option 3, good control without hypoglycemia. Option 4, improve quality of life. And option 5, reduce complications. You need to pick up one answer, and I will come to that what I think will be the right one. Then we'll match with each other. 1980s, when we are doing our training, MD, DM, late 80s, early 90s. So this was given by our teachers, and Rishi will remember very, very nicely that whenever you see a patient with diabetes, there should be 1-page format in front of you. That's it. Wherever you are in the clinic, discussion, or bedside, or wherever it is. You need to know the patient, who is the age, sex, or the socioeconomic status, for the patient symptom, the infection is there or not, active infection, or the treatment, and what is the knowledge, education, and the control. And when you come to the complication, you have acute complication, hypoglycemia, hyperglycemia, DKA, hyperosmolar state, infection, classic infection, common infection, and chronic infection, chronic complication like neuropathy, nephropathy, retinopathy. That's what this. And this brings to my first case. I want to show you 3 cases, okay, very quickly. This lady has diabetes for 6 years, HbA1c 7.3, fasting sugar 115. I won't think this is very bad. Creatinine 1.2, but if you calculate EGFR, it comes to 58. This is certainly something to worry about. Potassium normal, microalbumin positive, 30 to 300. This is higher range of microalbuminuria. Acceptable lipid, no neuropathy, stable retinopathy. At this point, she is on metformin, sitagliptin, Lasix, olmesartan, rosuvastatin. So essentially, I have a diabetes patient who have a chronic complication like a nephropathy. Move little bit. This is the famous ATNA study which published in 1998. Our whole concept of management diabetes changed, and he clearly showed if you just have diabetes, even if you don't have any heart failure, heart problem, your risk of getting a heart attack is same as if somebody has already heart attack. And the term coined is that type 2 diabetes is a MI equivalent. And this has been shown from the Framingham Heart study, not only for the heart, but only stroke, not only for men, but also for women. So just type 2 diabetes is equivalent, and our approach is changed. So you have a typical type 2 diabetes without heart problem, and is an MI survivor. The risk of atherosclerotic cardiovascular disease are same. Our approach is also changed, which brings to my next patient. This gentleman has diabetes for 11 years with HbA1c 7.7, GFR 78, microalbumin negative, LDL raised, no neuropathy, mild retinopathy, positive TNT. On a health check. I sent for a coronary angiogram, found block, and angioplasty was done. And the patient was started on metformin, linagliptin, acarbose, olmesartan, rosuvastatin, carvedilol, icosapent. And our approach changed. So in the complication ward, in the chronic complication from microvascular, we have put a microvascular, and we are seeing here now atherosclerotic cardiovascular disease. That Sanjay told very nicely. Now, as the time progressing, we saw that a significant percent of the people with type 2 diabetes has a problem with the heart contraction, not coronary artery disease, heart contraction. Hardly 30%. 1 in 3 people have a normal systolic and diastolic function. Rest 70% have a systolic or diastolic or combination of both, whether you or not know. And this later has been changed to heart failure with reduced ejection fraction and heart failure with a preserved ejection fraction. And these people are undiagnosed heart failure, which can go into 1 in 4 people with diabetes. And this brought our third patient. This gentleman has diabetes for 6 years, HbA1c 7.9, GFR 68, microalbumin 12, acceptable lipid, no chronic complication, no microvascular complication. Diagnosed to have a diabetic cardiomyopathy with reduced ejection fraction 2 years back. NOAA class 2, sinus rhythm, normal blood pressure, angiogram, clinically insignificant block, but echocardiogram showed ejection fraction 36%. Classic example of heart failure with reduced ejection fraction. Currently on metformin, gliclazide, Lasix, olmesartan, carvedilol, and ARNI. There's a new secovetrol and valsartan combination. And this brought our third complication, acute complication, chronic complication, heart failure with reduced ejection fraction or preserved ejection fraction. And this brought the end. So we are talking about type 2 diabetes. We are not treating sugar, we are not treating kidney, we are not treating heart. Everything together you need to see. And that's the conundrum of it. Type 2 diabetes with heart failure, CKD, and atherosclerotic cardiovascular disease. So my job at this point to leave this one, that's what Sanjay has told, to come to this picture of heart failure and CKD. That's what the viscera, as I understand. So I'm going to take you to the kidney, then to the heart failure, not macrovascular disease, and some other bits and pieces. Kidney, quite a bit worsening picture. This is a bit of a global data. 30 to 40% of the people with type 2 diabetes will have CKD or diabetic kidney disease. And this is, as it shows, 1990 to 2002 increased very, very hugely, 94% increment. So if you see in x-axis, you put GFR. In y-axis, if you put a hazard ratio, and you are talking about end-stage renal disease in 3 categories of microalbuminuria: less than 30, normal; 30 to 300, micro; more than 300, macro. As the macroalbuminuria increases, every beat of GFR, your end-stage renal disease chance increases. Same is true for cardiovascular mortality and all-cause mortality. See the connection. We are checking microalbumin, we are detecting GFR, but we are predicting cardiovascular mortality and all-cause mortality. And that's the cardiorenal conundrum, which is important. This is the slide has been clearly shown by Sanjay. This essentially it says that is improvement of the heart failure with any of this molecule of this. DAPA-CKD, which significantly reduced the primary endpoint. I'll also quickly pass through. So, many renal effects of SGLT inhibitor have been proposed. One is decreased interglomerular pressure, which I will come to that. Obviously, they are hypoglycemic agent. They'll reduce blood sugar. They'll beneficial for the BP, arterial stiffness. They'll reduce the volume. They reduce the inflammation, fibrosis. I have a cartoon for this. They will also modify some of these angiotensinogen system, oxygen stress, and albuminuria. Albuminuria already we have documented. And that's the mechanism we call it tubulo-glomerular feedback. So essentially what you mean, in normal person, afferent arteriole, this is efferent arteriole, so afferent blood coming to the glomerulus, efferent going up. This is your tubule coming here, going out complete. So proximal tubule, distal tubule. And here, SGLT2 receptors will reabsorb your glucose and the sodium, so less sodium will be delivered here, and the macular densa will work normally, which will give a normal tubulo-glomerular feedback. Tubulo, macular densa here, tubular cell, glomerulo, afferent arterial feedback, so that the glomerular, intraglomerular pressure is maintained. Now, what is happening in disease? What is happening in disease? Your SGLT2 receptors are overexpressed in type 2 diabetes. The maladaptation, the word Sanjay used, overexpressed, so more absorption here and less sodium is coming. So decreased sodium delivery at macula densa will impair the feedback so that the afferent arteriole will get dilated. That's what we are talking about in a more complicated receptor manner. So there will be increased glucose sodium reabsorption, increased ATP in the ACE1 segment, macula densa, less sodium, macular densa ATP consumption is more, and ultimately the afferent arteriole will get dilated. So your tubulo-glomerular feedback is impaired. If you add an SGLT2 inhibitor, because this reabsorption of the sodium and the glucose is reduced, more will be delivered to the macula densa, and pictorially it will look like this. So you are inhibiting SGLT2 inhibitor, more sodium is delivered here, macular densa getting sense, constricting the afferent arteriole, so the GFR is normalization, no hyperfiltration, and that's what we try to mean conceptually about tubulo-glomerular feedback. In normal untreated type 2 diabetes, tubulo-glomerular feedback is impaired, and this is corrected when you give SGLT2 inhibitor. Not only this, actually there is a lot of complicated factor, and that's what I try to mean. Once there will be more reabsorption, they causes more reactive oxygen species, they cause fibroblast, they cause a fibrosis and hypoxia, and they cause an activation of the renin-angiotensin system. And all these can be corrected if we block this SGLT2 receptor so that more sodium is delivered here. Your tubulo-glomerular feedback has been taken care of. Your renin-angiotensin systems are normalized, and your ATP generation better, their fibrosis is less, and that's the beneficial. Bottom line, uncontrolled diabetes without treatment. This is what the picture, although it is an artist imagination, that's probably correct, a 3D imagination. Once you are treating with the SGLT inhibitor, this is the final picture. You see the fibrosis is less, hypertrophy is less, because the basic mechanism is tubulo-glomerular feedback. Let's come to the heart now. Okay, so one way your heart failure come because of myocardial infarction, coronary artery disease, myocardium working less. But another way is diabetic cardiomyopathy. So diabetic cardiomyopathy will diagnose when there is no significant atherosclerotic coronary artery disease. You remember my third patient where angiogram is insignificant block. So that is no major macrovascular disease. Endothelial dysfunction, insulin resistance, ultimately leads to heart failure. And not to forget, prevalence of heart failure is 2.5 times more in people with diabetes than general population. And these people are more risk, nearly 2 times more risk of dying. And this study showed even up to 50%, almost like 50% of the people with the diabetes have some form of heart failure. SGLT2 inhibitors showed the benefit, whether it's empagliflozin, canagliflozin, or dapagliflozin. And essentially, if you see heart failure with reduced ejection fraction, primary endpoint, all-cause death, quality of life, everything is better when you give dapagliflozin in comparison to the placebo. You remember the placebo arm also got a standard care of treatment. So a benefit has to be had because of dapagliflozin, which has been clearly shown in the DAPA heart failure study. One thing we are very clear. One thing is very clear. We are not seeing this. Hello? One thing is very clear, that we are not seeing this benefit because of diuresis, because diuresis does not increase mortality. There are studies available in the diuresis versus no diuretic. Your all-cause mortality, heart failure mortality, hospitalization is worse. So diuretics is not a treatment of chronic heart failure. That is only for symptomatic heart failure. And the mechanism of benefit has to be a multifactorial from everywhere, whether it's decrease in preload, decrease in afterload, decrease of fibrosis, decrease in oxygen demand, improvement of arrhythmogenic potential, and so on. But picture abhi bhi baki hai mere dost, and this is what they showed. We have 2 trials, Emperor reduced trial with empagliflozin, DAPA heart failure trial, dapagliflozin, which showed a wonderful benefit of outcome, heart failure outcome, cardiovascular death in both the molecule, people with diabetes. But a significant percent of this trial, both the trials, the people are included without diabetes, and they actually showed exactly similar type of benefit. People without diabetes, you are giving dapagliflozin, which is basically anti-hyperglycemic agent. Not only that, ARNI, which is one of the mainstay of the treatment, angiotensin receptor neprilysin inhibitor, whether they're on ARNI or not ARNI, the benefit is same. So on the top of ARNI, people need to be on SGLT inhibitor at this point, either empagliflozin or dapagliflozin. We'll quickly move to the other. Here I need to do an Indian trial about the liver in the fat, study done with empagliflozin, and which actually showed very nicely with the MR picture from the baseline to the post-treatment. If you give, it reduces the liver fat. We know how common is the problem with the fatty liver and NASH, and the similar data is there exactly with the dapagliflozin. So we are now, cardiologists used to take our people, nephrologists take our people, and the time has to come, the gastroenterologist also will take our molecular treatment of the people treatment with the diabetes. So in summary, the viscerometabolic benefit, main heart and the kidney, but also in the liver. But there are some in vitro data available that their beta cell protection, other visceral event, that lipolysis, that the fat tissue, this can be decreased. That not only the liver, otherwise in the body, which are abnormal fat, like by particularly mesenteric fat. And not surprising, if you see the latest guideline, then you have been seeing this hundreds of times. That's atherosclerotic cardiovascular disease, that's heart failure, that is kidney disease, that is minimize hyperglycemia, that is minimize weight loss, and the cost issue. Everywhere we have SGLT2 inhibitor, other than this group. And the good news today is that, at least in my country, we have molecule, original molecule, available at less price, so we can use the molecule even when cost is a major issue. I'm talking about dapagliflozin being available at the lowest price. So I'll come to my initial question. So aim of treatment for the type 2 diabetes. I have given 5 options: reduced HbA1c, reduce symptoms of high sugar, good control without low sugar, improving quality of life, and reduce the complication. I totally agree with you. All of them can be correct, but if I have to choose one, this will be my right choice. We need to move out from glucose-centric approach to organ protection approach, because few people are actually dying of high blood sugar. More people are dying of complications related to high sugar. So we will be using the anti-hyperglycemic agent, but we will be choosing agents which are particularly good for reducing the complication. So if you come back to my first patient, which is a elderly lady with HbA1c almost okay, microalbuminemia, decreased GFR, what will be your next addition? Has to be dapagliflozin, because it will reduce HbA1c without hypoglycemia and protect the albumin and the kidney. My second man was 65 with an atherosclerotic cardiovascular disease. We need to start an SGLT inhibitor, either empagliflozin or dapagliflozin. I have showed it dapagliflozin particularly because the cost availability is less. And my third one, which is normal coronary artery disease, but heart failure with reduced ejection fraction. The classic molecule on top of your ACE-ARB or beta blocker, mineralocorticoid receptor inhibitor, ARNI, has to have a dapagliflozin. That is the data today available, and we can really save them from mortality and improve the quality of life. I'll rest my case here and look forward for interesting interaction with Chairperson and Sanjay and the audiences. Thank you very much for your patient hearing.
Thank you, Dr. Arpan, for good and very insight talk. And I would say one thing, that you really worked hard in making your slides preparations. All these things were really interesting. There are a lot of questions and we have less time, but I'll ask one question which is cropping in my mind. First question to Sanjay. Sanjay, can SGLT2 inhibit? This is a hypothetical question coming in my mind, and you are a very innovative person. All these big names, glycemic happiness and all these things came through you. Can these SGLT2 inhibitors be used as a primary prevention? Maybe risk group, maybe non-risk group.
So, sir, when we use the word primary prevention, it means we want to prevent a disease when the disease has not occurred, but the risk factors are there. So, depending upon our endpoint, do we want to prevent diabetes? Supposing we are talking about that, then primary prevention will mean that I begin using SGLT2 inhibitors in a patient with pre-diabetes. People are using, but there is no strong evidence for that. Supposing our endpoint is cardiovascular disease, atherosclerotic cardiovascular disease, and then the question is, I want to prevent ASCVD. Can I use it in a patient who has risk factors for ASCVD, for example, diabetes? But there is no established ASCVD there. For that, for dapagliflozin, sir, the answer is an absolute yes. Because when you look at all the studies that have been done, they include patients who have risk factors for ASCVD, but who do not have established disease. So there the answer is an unqualified yes. We can use it for primary prevention.
Right. Thank you so much. Another question to Dr. Arpan. While you were speaking, I thought you are not covering liver, but you eventually covered liver, NASH and SGLT2 inhibitors. There is a reasonable amount of data. My question is, SGLT2 inhibitors are preventing in terms of renal deterioration. They are also used in heart failure deterioration. Hypothetical question again from you. What do you feel its role in CLD? Suppose a patient has developed NASH, CLD is very common, and if you use this, do you anticipate the progress of CLD to be retarded? I don't know.
Well, if you talk about anything, my answer will be completely conjectural and my idea. See, if you tell about a child liver disease, cirrhosis of the liver, as nothing can be reversible from there. But in the early stages, it can be, but At this point, we don't much of data, but whatever data we are seeing a very small group of people. But my point will be, we are talking about NASH in person with the diabetes. So I certainly will use the molecule, take the extra benefit, because I have a benefit on, is a diabetes molecule. I have a benefit for the heart, I have a benefit for the kidney. Why not take an extra benefit for the NASH? But if you tell somebody with a non-diabetic and coming with a NASH, enzyme is elevated, we are not going to do any biopsy to document, but if its enzyme is elevated, more or less clinically it is a NASH, are you going to use a gliflozin? Well, it will be difficult. I know because of the cardiologic data, both for Emperor reduced and DAPA heart failure, people without diabetes with a heart failure, we are using dapagliflozin, not we are using, our cardiologist colleague are using, because we don't get to see those people. We only get to see the people who have diabetes, but cardiologists are using. But sooner it may happen that gastroenterologists also will start using a small dose people even without diabetes. But I think that's thinking much. At this point, will not make it a big issue. But this is a wonderful molecule. That's absolutely clear.
Yes,
I will agree with sir. Yeah, as of now, we cannot recommend for using SGLT2 inhibitors in non-diabetic NASH. But there are studies which show that EMPA is actually able to improve liver histology. And when you look at the drugs that are being used currently in hepatology, vitamin E, ursodeoxycholic acid, they are more of window dressing kind of drugs. Window dressing in the sense that they bring down the liver enzymes, but they actually do not change the histology. So these drugs do impact histology. There is one very good study by Dr. Amrish Mittal's team from New Delhi, where they have shown that they used an MRI, and they show that with that hepatic fat content has gone down. But we need more robust data from a wider spectrum of patients before we can actually begin propagating its use. But we should keep our minds open.
Yeah, thank you both the speakers. Now it's time for Q&A. So lots of questions are there. So I'll read one by one and I'll request one by one to answer. Dr. Praveen Mittal is asking, keeping in mind the benefits of SGLT2 inhibitors, can we be given in thin and lean diabetic patients also? Lean patients also. Dr. Sanjay, would you respond to this?
Yes, Dr. Praveen, thank you. We should be able to differentiate between thin, malnourished people and thin or lean, healthy people. If your patient is healthy, feel free to use the drug. It is very safe to use. However, if your patient is malnourished, the patient has symptoms or signs of protein energy malnutrition, that is macronutrient malnutrition, and maybe micronutrient malnutrition, then there are other better drugs to use. If actually you have a malnourished adult diabetic, think of LADA, think of pancreatic diabetes, and think of insulin before thinking of the other drugs. But if your patient is healthy, we can use very safely. Also note that there is something known as normal weight obesity. This is a term used in many countries. In India, I think Dr. Nitin Kapoor is heading research on this. Normal weight obesity means that your patient has a high fat percentage, more than 30% in women, more than 25% in men, but the overall BMI is the same. If you have a patient like this, you do not need to do a DEXA to actually look at the fat percentage. You just the waist circumference. There is central obesity. Then these drugs are helpful because SGLT2 inhibitors, they preferentially reduce the central fat, central adiposity. You will also have some lean and thin patients who have ectopic fat deposition. For example, NASH, polycystic ovary syndrome, obstructive sleep apnea because of deposition in the retropharynx, epicardial fat. These are all ectopic sites of fat deposition. If you have a lean and thin adult, overall healthy, with diabetes and with any of these, then again, this is a preferred drug to use.
Yeah, thank you very much. I'll add one line, Sanjay, into it. What has been observed with dapagliflozin, as the BMI is reduced, the number of kg reductions are also reduced. Like 3 kg above BMI 30, 25 to 32 kg, below 25, only 1 kg loss. So that is another thing that has been observed with this. Another question is similar questions. Dr. Santi Biswas, does SGLT2 inhibitors reduce weight in person with low BMI? Quick response from Dr. Arpan.
I think we had a slide, actually, we didn't show that, what exactly you tried to tell. So magnitude of weight loss is much more when the BMI is higher. So higher BMI, say suppose BMI is around 30, we can expect 4 to 5 kg weight loss, but BMI if it's 22, we probably expect 1 kg to 1.5 kg. So, I mean, the issue is the same. We will be treating the person and we will take this as extra advantage, the bonus advantage.
Right. Another question is from Dr. Pradhan. What drugs we should avoid along with SGLT2 inhibitors? Dr. Sanjay.
The first and foremost is carbohydrate restriction. Avoid keto diet. If your patient is fond of going on fasts every now and then, especially without telling you, then this is to be avoided. If your patient is going on a keto diet, you should actually counsel your patient very strongly about dietary pattern. If there is carbohydrate restriction along with SGLT2 inhibitors, chances of going into ketosis are more. Apart from that, there is no other drug that has to be avoided. You can give with each and every oral drug, each and every injectable drug that is available in the market. If you are giving along with insulin, be aware that there may be hypoglycemia. You may have to reduce the dose by 10-20% for insulin. Do not stop the insulin suddenly. Also, if you are giving with high dose diuretics, especially loop diuretics, be aware that blood pressure may come down, so you may have to reduce the dose of diuretics.
All right. Another interesting question is, can we safely use SGLT2 inhibitors in patients with eGFR below 45? The part A. And part 2 is, do glycemic benefits varies according to level of eGFR? As eGFR goes down, the blood sugar loading effect goes down. Dr. Arpan.
I think second part is very, very clear, and answer is boldly yes. So as the eGFR goes down, your glycemic efficacy comes down, because for a glycemic efficacy, you need a more and more functioning glomerulus. eGFR coming down is a reflection that your functioning glomerulus volume is coming down. That's very clear. Now, to use below eGFR less than 45, so at this point, in India, our licensing from DCGI is 45, but FDA is up 30. We have a dapagliflozin study available up to 25, DAPA-CKD, and we have studies of going on up to 15. So essentially, we need to understand these two things. So whenever GFR is say around 30, we will not be getting a lot of glycemic efficacy, but we are using dapagliflozin to protect the functioning glomerulus, to retard the progression of diabetic nephropathy. That definitely will get it. We will give them some other molecule. We may give them linagliptin, we may give them insulin for the glycemic benefit. But we will probably, the time is going to come soon that probably we'll be using SGLT inhibitor with a GFR of 30-25 to protect the kidney so that their time to go to end stage kidney disease is increased. That's what essentially we want. I mean, once we are born, we'll be dead, we'll die. There is no harm. So we want to get a bit of a good quality and quantity of life. That is our aim.
Another hypothetical question. Dr. Sandeep Sinha, any role of SGLT2 inhibitors in other metabolic problems? Example, PCOS, polycystic ovarian disease. Dr. Sanjay, please respond quickly. We have 1-2 more questions.
There is certainly there is a potential advantage. NASH, Dr. Bhattacharya sir has already discussed. Polycystic ovary, if you give you have to give contraception, because the chances of weight loss are there. It is possible that ovulation may occur, and then we will get in trouble actually. So contraception has to be given along with it. But certainly there are potential benefits, and I think that is the way forward. People will begin using these drugs for these indications.
Stroke, we have already discussed, but quick response. Do SGLT2 inhibitor have any protective role in patients with stroke? Dr. Arpan.
Well, EMPIRE trial actually showed the chance of statistically little bit of it more, the stroke, yes. But subsequent study did not show. Also, the other thing is that hemorrhagic stroke chances coming down. So at this point, we will not be focusing it as a beneficial effect. But at this point, we will just keep an eye, but don't tell anything extra advantage we are going to get it. So basically, now this is a very interesting question. Actually, this is not just a bypass question. You are talking about macrovascular disease. You are telling it's coronary artery disease is wonderful molecule, and you are telling cerebrovascular disease can worsen. That's become, but absolute numbers are very less. It is difficult to do statistics at this point. We'll keep an eye, but we will not make any comment that it is better or worse for the stroke.
We should keep it at this point as a stroke neutral. I think this would be, yeah.
Yes. Yeah, agreed.
I think coming to last question, this is practical question. Which agent is better in pre-diabetes? Metformin, DPP-4 or SGLT2? Dr. Sanjay, 1-2 line, and Dr. Arpan. This is a concluding question.
Number 1, lifestyle modification as proven by multiple studies. Number 2, metformin.
And Dr. Arpan?
Yeah, I think gliptin and SGLT2 inhibitor at this point will not be using. So lifestyle plus metformin. Lifestyle should come first, but I wish I know what is called lifestyle. It's very difficult. It's very easy to give a lecture and you one side of the table to tell you do this and you do this. Is very difficult. In some of the doctors meeting, not now, not the virtual, the physical meeting, I just used to ask how many people, how many doctors you do 30 minutes a day exercise 5 days in a week. Hardly 10% will stand, 90% will not stand. So it's very easy to give a lecture, but yes, Sanjay is absolutely right. Studies have shown lifestyle causes the weak prevention. But along with that, if people are very interested, suppose family history, father has diabetes, I want to prevent. Yes, you do exercise, BMI maintain, WHR maintain, use metformin up to 1 gram. Will not go more than that.
I think if I club both of you, the answer is lifestyle 1, and those who are not able to stick or those who are partially compliant, at least use the benefits of some molecule. And SGLT2 also has been used. The expression of frank diabetes has been reduced by, I think, 37% or so in all these trials. So anyhow,
Yes.
I enjoyed
Sir,
my...
Dr. Rishi sir also, now what Dr. Bhattacharya said is right about India. When you look at the diabetes prevention studies from Finland and from China, lifestyle modification was superior to metformin. But in the Indian study done by Dr. Ramachandran, lifestyle modification and metformin were almost the same. So
Yes,
there is a
yes.
greater role for pharmacotherapy in our population. Also, when you see data for BP lowering with dapagliflozin, for example, what you see is that Indians respond better. So that also we have to keep in mind.
Why so? Any answer?
Maybe
Why
sir, we are
Indians?
more sensitive. The same we see for DPP-4 inhibitors, GLP-1RA, and for SGLT2 inhibitors.
I think,
Yeah,
thank you.
actually, the data are very, Sanjay had one slide actually. Average systolic BP reduction 4 to 5, and Indian cohort up to 10 systolic BP reduction was there. Although the Indian cohort is much smaller than the rest of the study cohort.
At the end, thank you for the speakers. Dr. Arpan, my good friend. Dr. Sanjay, a wonderful young, enterprising young man. I enjoyed 1 hour stay with both of you and across the India. And thank you, Amit, for the opportunity. Now, back over to Amit.
Thank you, Dr. Rishi. I think first of all, we must thank all the participants. We had more than 1,000 delegates who attended today's symposium.
Thank you, all of them. Thank you.
Yeah.
Thank you.
And I think that tells us about the interest SGLT2 inhibitors has generated. And I think one line which Dr. Sanjay has spoken in his lecture, that SGLT2 inhibitors are for humanity, it sticks to my mind. And I think both the lectures were full of take-home messages. And, as a pharmaceutical industry professional, Dr. Sanjay gave a lucid example of, CKD patient and how, you have to look at the clinical symptoms in the patient and then prescribe if the eGFR is around 30. And secondly, Dr. Arpan's, question, the first slide, that what is the aim of or objective of the treatment. And when he says reducing complications is something which is wonderfully done, sir. And I must salute both the speakers for their, mind-blowing lectures today, the amazing command of this over the subjects. Thank you very much, both of you. And finally, I would like to say thank you to Dr. Rishi Shukla. Your presence in the program has really made immense difference to us, and we are really grateful to have you here. And the way you conducted the session, the way you opened the session, that was phenomenally, well. So thank you very much, all of you from Intas. There are 2 announcements we would like to make, sir. Dapavel is available all across. It is less than, it is very affordable, just 12 rupees. And we are introducing Dapavel M, which is dapagliflozin with metformin combinations. And we have 4 variants for that: Dapavel M 500 and Dapavel M 1000, 5 and 1000, 5 and 500, and 10 and 500, and 10 and 1000. And metformin is extended release, so that makes it truly once a day. And the price is even lesser than plain dapagliflozin. So Dapavel M 10 milligram is just 10 rupees a tablet. So you can prescribe this to more number of patients. So with this, I must say thank you to all of you for joining in today, and namaste from here at Intas, and thank you very much once again. Good night.
Bye-bye and good night. Good night. Bye-bye.
Thank you, everyone.